Alrighty. Okay. And let me just welcome everybody to PNR 203 Exam 2 review. And I'm going to share my screen and bring up my PowerPoints that are on Canvas for all you, and so that you can see it. Now, at any time that you don't understand it, let me say it again, stop me, okay? All right, so what we're going to do is that this is on chapters 6, 7, 8, and 9. They're good chapters, guys. They have a lot of information in them. So, like you've already studied all the different complications of pregnancy, and you got your topic, you got your placenta previa, you have your hydiniform mold or molar pregnancy, and so these are really good little cartoon. If you don't know them, I would suggest that you write down your little cheat sheet. So if I was to ask you a question, okay, and you can all unmute yourselves. If I was to ask you a question, what is painless red bleeding? What would you tell me?
Placenta previa.
Placenta previa. Good, good, good. Okay. If I was to ask you what condition is the patient in if she's having a rigid board-like uterus?
Placenta abrupto.
A placenta abruptio. Okay.
Yeah,
It's abrupting off that wall, that endometrium, right? Now, what type of delivery would this patient have?
C-section.
C-section. Good, good. Yeah. It would be pretty quick, wouldn't it? Now, going back to our placenta previa, right? We got painless red bleeding, right? Bright red bleeding. What type of delivery would this patient have? You got a placenta, you got to say you have a complete previa. You would have you have that placenta right over that internal os is complete previa. Guys, write down you would have a C-section. Okay.
Mm-hmm.
Yeah. You can remember when something's over the cervix, such as the huge placenta, and remember something, it's a very vascular area. So if that was laying over the internal os and you try to deliver her vaginally, you would have a hemorrhage. You lose your patient. So that kind of patient would have a C-section. So you might see those kind of questions. All right. So we're going to go on and we're going to start. I think it's chapter 6, or anyway, culture influences on birth. Remember, culture is really important to the patient. And one thing, remember the 5 P's or the 4 P's of the labor birth process? One of them is psych, correct?
Mm-hmm.
Culture has a direct influence on her psychic. When she feels that she's at home in the labor room and the nurse respects her culture, she will relax more. That's your ultimate goal in that labor room, is to give a relaxing atmosphere. So let me give you an example. I had a patient, and she's an American Indian, and
Oh.
she had a lot of her tribal members there. Okay. And she looked at me and she said, would you mind if my tribe comes in and just does a little, ritual? And I said, sure. Okay. So I got the clearance for them to come in, and they surrounded her bed and they did the tribal dance and chanting. And you know what? That really made her feel really great. So we have to be, as nurses, very sensitive to the needs of the patient, to the culture of the patient. And I was that day. I'm going to tell you, let me tell you the outcome. She had a beautiful labor, handled all the contractions, just so wonderful. And guess what? We had a beautiful vaginal delivery and a night, and everything worked out. So let me ask you a question. Was I, oh, oh, hold on just a minute. Was I, as a nurse, was I culturally sensitive to this patient?
Yes.
Yes. And that's what
Yes.
my point. Yes, I was culturally sensitive. So that's my point. You want to be. Because we want to show the patient that we are meeting their needs. We're sensitive to their needs. The nurse's role is to be active and therapeutic listener. Okay. And we always demonstrate culture sensitivity. And in our world, we have a very diverse world. So we must be culturally sensitive. Now, on these kind of questions, I can tell you something. These kind of questions, be careful how you read the question. Okay. You never know, they might put something different on there, like cultural insensitivity. If somebody's insensitive, that means they not contributing. Like if I was insensitive to that patient that I described to you, then I would say, no, you can't have that. What do you mean you're going to have your tribe come into the labor unit? You know, that would be insensitive. Everybody see the difference between cultural sensitivity and insensitivity?
Yes.
Yes?
Yes.
Oh, okay, good. Okay. All right. So another influence is when someone you comes in and you don't speak their language. In labor room, we had to jump on that really quick. So we had to get an interpreter because we're in the labor room. There's a lot of very sensitive things, items and issues. So we get an interpreter. So whenever appropriate, you must get an interpreter. Now I know family members might just want to jump in and say, "Oh, I can help you," but what does that make the patient feel if her own father is going to be an interpreter in the labor room? What do you think?
Not feel comfortable.
No, she don't
Not
feel comfortable.
confident. Yeah.
Yeah, imagine. So we know in our hospital that I worked for many, many years, we had what we call the blue phone. And that just hooked right into the wall. And you can have every language that you possibly could think of on that phone. So remember, and that goes for any unit. If you're in the med surg unit, wherever you're working, ER, you're going to have to use an interpreter. Okay. And I like the blue phone because, half the times the patients that had a hard time communicating with because of the language barrier, they came in at 3 o'clock in the morning. And so getting very hard to get a real person to come in to interpret. Okay, so I got a little brain teaser here. Now I name my questions brain teasers because they kind of tease your brain. So here it is. Which of the following nursing actions demonstrates cultural insensitivity in the care of the laboring woman?
B.
E.
B. Correct. You got it. Okay, you got it. So we're going to move on to now what makes up the birth process. So a lot of your breeding, you might have read the 4 P's of the labor and birth process. But as L&D nurse, we put in that number 4 position. But the main thing what you want to learn here is the powers, which are what? Those uterine contractions, right? The uterus needs to contract. And remember, the uterus is made up of 3 different muscle fibers. So when it contracts, guys, it is powerful. It normally a good contraction is equal to about 50 millimeters of mercury. That's a lot of pressure. So don't forget, she's feeling that pressure, and so is the baby. So we have to have those contractions. And part of the contraction, you have how often is it coming? So that would be your what? Frequency. How often? Okay. A good contraction pattern, 2 to 3 minutes apart, and they're regular contractions, not irregular, regular. So frequency is from the beginning of one contraction to the beginning of the next contraction. How often are those contractions coming? You might want to write that down so that you have it down pat. Okay. Now, duration. I want to know how long they're lasting. So you count the seconds 10, 20, 30, 40, 50, 60. A good contraction lasts from 60 to 90 seconds in duration. We don't want them any longer than that 90 because baby says, hey, I've got to get oxygen in here. And every time mommy has a contraction, that decreases the blood flow, decreases the oxygen that goes to that baby. So that's why the duration, you can't have it too long. So the duration, the definition would be from the beginning of one contraction to the end of that same contraction. So write it down like that. The beginning of one contraction goes to the end of that same contraction. So I want to know how long these are lasting. Now, intensity is how strong they are. Well, you're using external monitoring. So intensity would be approximation of how strong they are. And we classify them as mild contraction, moderate, or strong, okay, or firm. And so when I teach this, I'm teaching like just like I would teach a new nurse in labor and delivery. So I want you all to take your finger and touch your nose, okay? Touch the end of your nose. Now that's considered a mild contraction, okay? Now take your finger and put it on your chin. Feel your chin. See, now that's a little bit more, so that's moderate. Now take your finger and go to your forehead. That's a pretty firm contraction. At the end of the transition phase of the first stage of labor, you're going to have strong contractions. They're going to be as feeling your forehead. So that's how we classify our contraction. Now, the baby has to come down, right? So we're going to have it called the passageway. Got to find his way down so that he can be delivered. The gynecoid pelvis, as you know, is the most favorable for vaginal delivery. Gynecoid. The planetoid is a very flat-looking pelvis, and that's not favorable for vaginal delivery. You know, it's very hard to get a baby's head through that type of pelvis. So the passageway is one of the P's. The passenger would be the baby or the fetus. Then they got the position. So I know you talked about position such as occipital anterior, which is OA. That's the best. Let me tell you, occipital anterior, where touch your back of your head. See now how I'm touching the back of my head? Now the back of the baby's head is actually tucked down and facing the mom's interior, her front. So now the head is nicely tucked down. Perfect. He can make his way down that passageway. Now, OP stands for occipital posterior, where the back of the head, see my head, back of my head, now the back of the head is leaning back toward mom's posterior. And so his chin is up in the air. It's hard to get a baby down the pelvis that way. But guess what? You can deliver OP. Write this down. OP equals more pain. They have a lot of back pain. Oh, a lot of back pain. And when you come down to the pushing stage, which is your second stage of labor, when you come down to pushing, it takes longer to push that baby out. So OP, she's going to work really hard on that one. Now, OT stands for occipital transverse, where baby's head is transverse in the pelvis. So he's like laying sideways, horizontal, his head. So it's a bigger diameter coming through, and it's very hard for that baby to fit. So a lot of times as practitioners, we try to go up and we try to move the baby into either OP or OA position, get them out of OT. And the last P stands for psych. Every patient needs support. When you work in labor and delivery, you're giving a lot of support to the patient. Even if she does have somebody in the room, she needs guidance. So there's a lot of emotion going in on that in the room with that. And if she doesn't have anybody with her, which I've had patients not to have anybody, what happens is that they get a doula. Okay, a doula. A doula will give support to this mom who's laboring really hard, and she's like an advocate. So write that term down, doula, because you might see that one again. All right. So let's go over the uterus. Okay. The uterus itself, after delivery, will have to involute. It has to go back down to the size of what it was before. So that's a term called involution. And then you have the uterine lining, which is your decidua, which is your endometrium, that's shed when the placenta is expelled. So, that's let me ask you this question since we're here. What stage of labor is the placenta expelled?
Stage 3.
Good. Wonderful. Okay. And so usually the descent of the uterine fundus, which is the top portion of your uterus, is usually 1 to 2 centimeters each day. Okay. Those after pains that, women complain about, they're actually contractions. And what we give them medication after delivery called oxytocin. Write that down, oxytocin. And we give that to contract the uterus. Because we want to prevent. What are we preventing? Hemorrhage, right? Hemorrhage. Okay. All right. And then you have your lochia. These are terms that you might see again next week. So lochia. So rubra is bright red, right? And that lasts from how many days? It's about 3 days in duration. Okay, it's your first 3 days. Then you have the drainage, the lochia gets to go to serosa. And the serosa is more pinkish. It has blood and mucus in it. And then that goes from like day 4 to like day 14. Okay. And then after that, it gets lighter and it goes to lochia alba, which is the white mucus. It has a lot of WBCs in it. Okay. Now the cervix will be stretched, of course, during childbirth. It does kind of shrink a little bit, but it never goes back to the original size. No. And once something is stretched so greatly, it never goes back. And then that's why when we talk about multigravidas in labor, okay, so say she's a gravida 5, para 4, all right? Is she going to go faster than a prima gravida? Anybody?
Yes.
Yeah,
Yes.
she's going to go faster because her cervix has been stretched, been open. And so that's why you never trust. The saying that we have in labor and delivery, never trust a multigravida, but she will surprise you. Okay, and then the vagina, you have the rugae. Now, during childbirth, the rugae is very smooth. Those are your vaginal folds. And so during childbirth, it gets very, very nice and very soft, so allows the baby to come down. After she delivers, it will reappear. That's usually about 3 weeks. Okay, and then you have the breasts. We're going to talk about engorgement and nursing care. Now, I want to hit upon this because you probably see a question on this one. It's called the episiotomy. It's in the perineum. And you have 2 types. You have midline, and then you have the medial lateral. Now, the midline is straight down. Okay. And then you have the medial lateral, which is over to the side. what I want you to remember is the assessment. It's called RETA. Can anybody tell me what RETA stands for?
Redness, edema, ecchymosis, and approximation.
Yeah, exactly. We're going to look at her bottom and we're going to make sure. Now, don't forget, this is, having an episiotomy is like having surgery. Okay, we had to open up her perineum and to allow the baby's head to come through, right? So it's just like a surgical cut. And so we want to assess to make sure there's no what? Infection. We don't want her to get an infection after delivery. So we're going to assess for redness. The swelling. Now, a lot of ladies after delivery are pretty swollen, and that can happen. But what do I apply? What can I apply to make sure that the swelling will go down?
An
What
ice pack.
Ice pack. Yes, ice pack. Good. Okay, that's exactly right. Ice pack. Write that down. Don't forget that. And then you got ecchymosis, which is bruising. And a lot of ladies bruise. And no matter what we do, we got bruising. So the ice pack will help that. It hurts. It definitely hurts. Now, the other one we're looking at is called approximation. And when you have a surgical cut and you're going to suture them back up. So here's my hands. I have one hand against here, see? So it looks like this approximation is pretty good. All right, so I'm going to look at it to make sure that the sutures are nice and approximated together. Now they will give a little bit, but we don't want to give too much because we want to make sure that she heals wonderful because that's her future. So we don't want her to have an ugly scar in her perineum. So we make sure that it stays nice. So that's called RETA. All right. And then here is your Colpax. Definitely Colpax. And then for medication, for the episiotomy, you have Dermaplast and you have Epifoam. They really do work good. And then, of course, you have your ice pack. Now, one thing you have to be very careful of is she will, since she delivered in due time, usually about 6 to 8 weeks, her menstruation will come back. Her cycle will start all over again. And a lot of times during this time, women are breastfeeding, but they have to be breastfeeding at least 10 times a day in order that they don't ovulate. Now, I've had patients where they came in for their checkup and they didn't wait for their 6-week postpartum checkup. And guess what? What do you think? What do you think they were already?
Pregnant.
They're already pregnant again. Yeah. Oh my goodness. And they were shocked. Okay. So that's part of our teaching. We do a lot of teaching, don't we, in nursing? So which nursing intervention should the nurse include for a client immediately after delivery to reduce bleeding and bruising of the perineum?
D.
D.
D as in dog. Good. Not warm. Apply ice. Ice, remember something. Ice is your best anti-inflammatory. All right. Now we're going to go into and discuss about contractions, okay? Because there will be a question about the contractions. So I want to make sure that you're well versed on that. So the contraction, what do you think contractions do? What's their purpose?
To open the cervix.
Yeah, to open the cervix, to dilate and efface the cervix. Remember, the cervix is long and thick during pregnancy. And it should be, because we want to keep that uterus nice and sealed up and tight, okay? But when she gets closer to now term, she starts having contractions. And she could start having those Braxton Hicks contractions, which are irregular contractions. But we want the regular good contractions. Regular, what I say by regular, I mean like rhythmic, has a rhythm to it. They're every 2 minutes or every 3 minutes, 3 to 4 minutes, but they're regular. Okay. So that's a contraction. You have to have effacement of the cervix, which means softening of the cervix, means what happens is that the internal os moves up and then the external os starts to come up when the internal os goes up higher, and then it all opens up. Okay, that's what we're looking at. And of course, dilation, you go from 1 centimeter or 0 to 10. Write this down. You never push a patient before she's 10 centimeters. Never. If she's like 9 centimeters, completely effaced, and say at a -2 station, and she says, oh my gosh, I have such pressure to push, what would you tell her?
To blow candles.
Blow out that candle. Absolutely. Good. All right. Now, the phase, each contraction is self. And I do have a picture here. Each contraction itself has 3 phases. And so here you have the going up. It increases. So that's called increment. It's increasing, is it not? It's going up the little hill. We get to the top of the hill. That's called the peak or the acme of the contraction. That's the strongest part of this contraction. Then as the contraction now lets up a little bit, it goes down, it's called, or decreases, is called a decrement. So now we go down. And then we get down to this area right here, and this is kind of a resting zone, resting area. It's called a resting, uterine resting interval. This is where she takes her, thank goodness I can breathe again. Okay. And then she gets ready for the next one. So during this time, you as the nurse are going to coach her to slow chest breathe here, okay? As long as she can do it, in and out. Breathe in and blow it away, slow and easy. Keep relaxed, okay? Then when she gets to the acme or the peak of the contraction, she may have to revert back to what? That he blow. He blow is a much quicker breathing, okay? Because my goodness, this is intense pressure, tense pain. Okay, then thank goodness it only lasts about 10, 20, 30, 40, maybe 40 seconds in duration. And then it starts to decrease. So here, right about down here, so she's doing her slow chest breathing through here. And right about in here, she goes, oh, and then you tell her, take a deep breath and then blow it out. And now relax. And then she relaxes. And then she has another one. So this is the phases of the contraction. Okay. And we talked about frequency, and here I have it right down here for you, is the time from the beginning of one contraction to beginning of the next contraction. Okay? Frequency. Duration is the time from the beginning to the end of one contraction, a single contraction, the same contraction. That's how long is lasting. So going back to my little picture, this little blue zone in here, see here, I got my little pointer. This is duration. You're talking about only one contraction, okay? Okay. When I'm talking about frequency, I'm talking about how often they're coming. So I'm going to count from the beginning of this contraction all the way to the beginning of the next contraction. That's frequency. Okay. Does everybody have those terms down?
Yes.
Yes.
Good. Because that's where a lot of students miss out on test questions. Okay. So here I had what's a definition of a duration or frequency, so you all know it. And how does the nurse assess intensity of the contraction? We talked about that already. Okay. And the Braxton Hicks contractions, these are irregular contractions. They can begin early in pregnancy and they intensify as the woman gets closer to term. You know, there's been research on that. There's been research as these irregular contractions, maybe they do something. but it's nothing for certain. I always tell my patients, especially when they say, "Oh man, I'm having these irregular contraction nerves," I go, "Yeah, but you know what? At least your body's trying to rib up." I used to say that to my patients, and they go, "Okay." All right, this is a diagram that comes right out of your textbook, but I do like it. It's just what I've been talking about with the internal os. So here's your cervix. Here's the external os. Okay? And then up here is your internal os. And so you're going to have this nice cervix. It's nice and thick, okay? Because it's protecting the baby in the bag of water and the uterus, keeps everything intact until it's time to have the baby. Then as she labors, okay, and has those very powerful contractions, then you can see how your external os starts to what? Get wider. The internal os starts, see how is brought up into the cavity. See here? And so eventually then all you have is the external os. And so again here is thinning out. So she's effacing. The cervix is getting what we call paper thin. And then when she gets really paper thin, she dilates really nicely. So in this picture here, you can see that external os is wide open and the internal os now is way high, is all moved out of the way. And so it's really remarkable how the body really does a good job with that. So one thing I want you to always remember, it takes contractions to efface and dilate the cervix. And that's another indication that you know your patient's in true labor. Is in true, when she's in true labor, she's having rhythmic contractions, but she's also dilating and effacing the cervix. Okay, I think we got that pretty well down pat. So here's the different lies. So all the definition of a fetal lie is just the position of the fetus, okay, the baby, in relation to mom's spine. So here you have what we call a longitudinal lie, and that just means that the spine of the baby is what? In line with the spine of mommy. See? Very nicely. So the longitudinal line. This one here, he's in transverse. Now this one would be a C-section, right? You can't deliver this baby vaginally. So, and these babies, I tell you what, once they get into a position such as transverse line, there's no change in them. Yeah, it's very hard, very hard. You could try maybe a version, but in transverse is very hard. Usually, if the baby's a breech, then we can try a version. All right, so here we go. So here is the different position of the passenger, which is your baby, and how the baby is presenting down in mom's pelvis. So we like these babies to be in complete flexion. You can see how nice and curled up he is, and he's ready to come on out. This is what we call full extension of the head. And then here is a poor flexion. Poor guy, is stuck there. Now you have a shoulder presentation down here, and what's presenting in the pelvis, which you can feel when you do a vag exam, is you can feel the shoulder. And so again, this is a transverse line. You can see how that you can't deliver that baby vaginally. That would be a C-section. And then you have your breeches. So you have Mr. Frank breech, where he likes to expose everything. So he's got his feet up here. That's how I used to learn it, the different breeches. So I call him Mr. Frank. He has his feet up by his head. So he's saying, okay, here I am, folks. Okay, come get me out. This one here is what we call a full breech. You can see where the sacrum, again, it's presenting with his buttocks. But these babies will be definitely C-sectioned, okay? But you can see how curled up he is in there, but he's in there the wrong way, okay? Now, this kind of baby with a full breech like this, you might want to try a version. If mom wants to, around 37 weeks gestation, you could try to turn the baby. But once you do a version, then you usually follow an induction of labor, because these babies, they like to be in the position they want to be in. You know, if they put themselves in this position here, they may have a reason. Sometimes you find that there's a short cord, okay? And when the cord is shorter, then he knows that he needs to be in a different position. All right. And then you have a single footling breech. You can see where the foot's coming through, okay? That would definitely be a stat C-section. All right. So here's your different classifications of fetal presentations and positions. So remember I talked about OA, so occipital anterior. So again, the back of the baby's head is faced to mom's interior. See up here, look at the pelvis here. Okay. So you see mom's interior right here? And then here's her posterior. Okay. And then she has her left and then she has her right. Okay. So when the baby is OA, occipital anterior, his back of his head is to mom's front, interior. Okay. And just the way he's laying to what? Her right side. So you call it an ROA. Now, this baby here is laying to mom's left side. Okay. And he's an occipital anterior also. Back of his head is facing mom's interior. Okay, these are nice to deliver, right? Now, here's your OP babies. You have occipital posterior, where the back of baby's head is now turned, right, to mom's posterior, right? So you can see now his chin will be more prominent coming down, where this guy here, his chin is tucked down. Okay. And again, left just means that he's lying to mom's left side. Okay. And here you have ROP, which is the right occipital posterior. And again, the back of baby's head occipital is facing against mom's posterior. Now you can definitely see in these pictures why she would push harder during the second stage of labor. And she would push longer. It's harder. They are harder babies to get out than if a baby was nicely tucked down like these guys down here. All right. So that's all it is to fetal presentation in different position. Let me tell you, when you're reading a question about fetal presentation, just read it carefully. You know, always ask yourself, what's the question asking me? And then you go back and reread the question again, and it works all the time. It comes to you, and oh, that's what they're asking me. Okay. And the last P would be what? The psych. Be her mental state that can influence the course of labor. Yes. I had patients where they come in and they're so uptight. And, you know, they're just clenched, you know, their teeth are clenched and they go, I'm really scared, nurse, you know? And I go, I understand. And I try to relax them a little bit. And we do a little bit of slow chest breathing and some imagery. And I use that a lot, imagery. Okay. I use a lot of non-pharmacological methods to get my patient what? To feel comfortable and to relax. I always told them, you're not going to dilate and face the cervix if you're like stiff as a board and hard and it's like a brick wall. You cannot open a brick wall. So they kind of use that. That imagery really does work well in the labor room. So psych. All righty. So how do you know? How does these patients know that they're going to go into labor? Okay. So bloody show is really very good because bloody show, write this down because you may see this one again, is that mucus plug that gets dislodged from the cervix. Remember the cervix, right? That picture of the cervix. Well, in that area of the cervix, you have like a plug, and it's a mucus plug. And I tell you, it's really thick mucus. And that stays there in order to prevent any bacteria from ascending up into the uterus. So that mucus plug does have a big role in her. So that's as a sign when they lose this mucus plug and they have this bloody show, that means that they lost the plug. That means their cervix is starting to open up. I love it. I love when patients are like, I use a lot of hydrotherapy with my patients. So I have them in a shower. And they're really relaxed. You have that warm water going over their body and they just really relax. And all of a sudden I see down their leg is this mucousy blood. Okay. And I go, yes. And then she goes, oh. And I said, yep, your cervix is opening up from the relaxation that's coming, that you're relaxing in the shower. So that's a really good sign. Now, ruptured membranes is a pretty ominous sign that, yeah, something's happening. Now, write this down. You only have 24 hours to deliver that patient after she ruptures her membranes. Because once you get past 24 hours, then you have bacteria that's probably getting up inside that uterus and will cause her to have maybe a condition called chorioamnionitis, which is never good. It's a bad infection of the amnion and the chorion, which is the layers of the uterus. So you want to get her delivered. Okay. Now some people have a good energy spurt. You ever hear people like nesting? All of a sudden, they've been fatigued, and all of a sudden they get this. I gotta do the laundry. I gotta do this. I gotta get things ready. They have a lot of this energy, which is wonderful. But that's because labor is coming. Okay. Their body can sense it. I just love it. Okay. And then you have increased vaginal discharge. Okay. Again, sloughing off of the cervix. And remember those Braxton Hicks contractions I told you about, that irregular contractions? They can be very annoying, but remember I told you that they can actually get things started. And that's what happens. Okay, so let's go on now to how about we talk about station. All right, so here you go. So here's mom's pelvis, and here's the baby's head. So these little pointy little things here, these are the ischial spines. Now let me tell you, they're sharp. When you do a vag exam and you're going up and you feel those bony promises, then that's the zero line. Okay, zero station. We kind of cut that off right there. These are like our landmarks. So we know as nurses that anything above the zero station, ischial spine, is minus, like a -1, -2, -3, -4, and -5. That anything below the ischial spines is plus. +1, +2, +3, +4, +5. Okay. So that's how when we do a vag exam, we feel for them. And then we take our fingers across and say, oh, okay, he's above the ischial spine. So it'd be like a -2 station, or he's below the ischial spine, it could be a +1. When you get down to like a +3, you can really feel that head with no problems whatsoever. And the perineum starts to bulge on you. And then his baby is coming. So that's all that we talked about when we talk about station. Now, what I want to point out to you is that when the baby's head is like at a -4, -5, that baby's really floating. He's way high. You can take this head and push it all the way up here, and you can see where he's behind the pelvis. Now, he hasn't not dropped. He's not what we call engaged. And so he can be what we call ballotable, where you can put your fingers in, like and press up on the head, and the head goes up a little higher. So he's not engaged. Okay. Now, the reason why you be careful about this kind of position is that when her bag of water breaks, the cord, remember the cord is circulating in here. The cord then can actually float. This is all water, can float down and present itself before the fetal head. And that's called a prolapse cord. That is an emergency because babies, the head is going to put pressure against that cord, and the baby's actually cutting off his own oxygen. So we are very much aware that when a woman breaks her bag of water, you want to check fetal heart tones very quickly. Okay. So say she's in the hospital and, all of a sudden she rings the call light and she says, I think my bag of water broke. So you check and say, okay. And the first thing I'm going to do is put that electric monitor on, make sure that my baby's okay. And the second thing I do is I'll check And I can check to see if it's truly a bag of water by using nitrocene paper. And there's just a simple little litmus paper, and it lets me know that the bag is broken. So that's all that's fast station. All right, so this is pretty important because you probably see a question about the difference between true labor and false labor. Those are always good questions. So we talked about true labor a lot already when we talked about contractions. So I'm going to start here with true labor. So your contractions are gradually, they go into a regular pattern. We talked about it. They become stronger. Now, they do become stronger and more effective when you have your patient ambulated. So it could be a good question about that is, how do you make a contraction stronger is send your patient out walking. Okay. All right. And then you have discomfort in the lower back and the abdomen, and you have bloody show. I told you we talked about that. And that big one is you're going to have changes to your effacement and dilation of the cervix. So those are all what I consider true labor. Now, for instance, you're a nurse in the triage room. And so this patient comes in and, she's having her first baby and she's real anxious, she's, oh, yes, my contractions are regular. They're every 4 minutes apart. And maybe, and they're hurting me. And she's trying to tell you that, oh, yeah, she's trying to convince you that she's in true labor. Okay. Well, you put her on the monitor and her blood pressure is okay. And baby heart rate is within norm, 110 to 160. So we're doing good. The contractions, though, are kind of spaced out. They're not as close as she told you. And you checked her, and she's like 1 centimeter, 50% efface, and the head is about a -2 station. So everything is good. So you're going to try to get the contractions to become more effective. So what am I going to do? Send her out walking. All right. We usually send them out walking for 30 minutes, then come back in. I'll check fetal heart tones to make sure everything is good, and then send her back out. Now, after 1 hour and doing all that, if she doesn't make any progression in her cervix or effacement, and the baby's okay, baby's within normal, limits, and her blood pressure is okay, I'd probably discharge her to home. Go home for a little while. Of course, I get patients that are going, I'm home. Well, you're gonna have to go home. Okay, and then so that's true labor. So that does happen. That's the story that happens in those triage rooms. And then you have false labor, which are contractions are irregular. Okay, walking actually relieves. Now, if she gets going back here, I kind of messed up a little bit here. If the contraction becomes stronger, more effective, and she does have progressive effacement and dilation of the cervix, I'm going to keep her. Okay, but if by going out walking and they become less effective and she doesn't have any dilation and effacement of the cervix, then that's when I'll send her home because she's in false labor. Any questions about that? Are they clear on true labor versus false labor? So how about a brain teaser? So you have a laboring woman is uncomfortable and her labor has slowed down. Which instructions should the nurse give to the client to help stimulate labor? That's what I want you to get. Wow.
D.
Yes, good. Okay, good. All right. Let's go over a little bit about the fetus. Fetal heart rate is usually 110 to 160. Don't forget that. And then here's our monitor. And I want to share this with you because here you can see this is the fetal heart strip right here. This is the printout. And so you can see the accelerations of the heart rate. Okay. Remember, accelerations are A-OK. All right. And so then this here would be your contraction pattern. Okay. So remember those little contractions I showed you? Here's a little hill right here. All right. But they're pretty spaced out. You can see that these are not really really rhythmic regular contractions. Now the printout here, this is her blood pressure, 135/70, so that's okay. And her pulse is a little high because she's in labor. And this is our fetal heart rate. Now it's on the low side, but it's still within normal, But you know, you're going to watch him closely. But again, going back to the strip, he might run a low baseline, but he does have accelerations. So that's good. This number 22 here is actually the resting tone in between each contraction. So that's okay because the normal resting tone is about 20. So that's okay. Here we are in the labor room. Your patient is on a left tilt. Remember, we never put a patient on her back because of supine hypertension syndrome. So you have the monitor. The top one is the togonometer, which picks up your uterine contractions. And this one here is the electronic ultrasound, where you're picking up his heartbeat. Okay. And then she has her blood pressure cuff on, and we're monitoring her very closely. As you can tell, she's probably in early labor because she doesn't have an IV yet. And she maybe she'll go out walking. But this is a typical monitor with a hookup and the labor room. Okay. And then here I have another picture, HP monitor. This is the fetal heart rate 148. The top again is 148. Remember Veal Chop? So you always want to remember, you know, you're looking at the heartbeat. Now see these squiggly lines in between? Those are your beat to beat fluctuations. And that's where you're going to read about variability. So you want to have variability in your heart rate because variability indicates the baby's okay, we're well-being. Okay. Does this lady have contractions?
No.
No, this lady is not having any contractions. Is the fetal heart rate normal?
Yes.
Yes, it is. It's normal. Actually, is she having a contraction right now? She might be having a little one because you see the pressure gauge here is reading about 26. Remember, the resting tone usually is about 20. So she may be starting one now. Okay. All righty. Let's keep going. So when you have a low fetal heart rate below 110, what's that called?
Bradycardia.
Yeah.
Bradycardia. When's it greater than 160, what's that called?
Tachycardia.
Right. Accelerations are A-OK. All right. So what causes early decelerations? Remember Veal Chop. So it's VE, right? So what causes early decelerations?
Head compression.
Head compression. Good. Write that down. Okay. You might see that again. Okay. What causes variable deceleration? So variables, they have a sudden drop, but a sudden recovery. So what causes a variable deceleration?
Cord compression.
Cord compression. Good. And the last one, late decelerations. What causes a late?
Insufficiency, placental insufficiency.
Yes, uterine placenta insufficiency. So it's, remember something, it's never good to be late, right? It's never good to be late to class, right? So it's never good to be late. We don't want a late. When a late occurs after a contraction, so you don't want that to happen. That means that the baby is having a problem and he's not getting the blood flow that he needs to from the placenta to the uterus, or the uterus to the placenta. So you have uterine placenta insufficiency. It's not good. Gotta get this baby out. Again, it's not a reassuring pattern. It's not. It's a non-reassuring. So I don't like to see late decelerations. When I see late decelerations, I've got to watch this baby very carefully because he could be getting into a state of acidosis inside, having some hypoxia. I don't want that to happen. Okay, babies get very sick, and if you don't act upon it, you could lose a baby. Okay, so here we go. Here's your Veal Chop. So you know when you have questions like this on the test, you might want to just put on your scrap paper, write out veal chop and it'll come to you very quickly. Okay. And that's how you learn a lot of stuff because you're getting a lot of information very quickly. Right? Okay, so here's an example of a late deceleration. So again, it's the decel is occurring after the contraction. So this baby, what's this baby actually telling you is that, okay, nurse, I'm hanging in there during this pressure of the contraction, but I'm not getting what I need from the blood flow, the oxygen. So my residual in my lungs are really bad. My heart, I'm not getting what I need. So it decreases. See, it decreases. This is never good. And see how we still have a little bit of squiggly lines. And here it looks like he actually maybe had a movement. Because here you can see it's a little, let's see the peak of the contraction. And he's going, help me. And then here, do you see how we lost these squiggly lines here? If you watch the strip more, you would see that you would lose your variability, your beat to beat fluctuations, and that's never good. Okay, so that's why late decelerations are not good. They're non-reassuring. All right, so if I asked you, a nurse is caring for a patient in labor and she knows the fetal heart rate in the 90s after contraction, that's the clue, after contraction, which priority intervention should the nurse perform?
One.
You want to call that doctor. Now, in real life, I would turn this patient to her side and call that doctor. Okay. All right, so let's go now and review about amniotic fluid. Okay, so amniotic fluid, what color should it be?
Clear.
Clear, yes, clear. It might have some Flexivernix in it, but if the baby has a bowel movement, right, then it could be that now it's green stained. That means it had its first bowel movement inside, which is the meconium. Okay. Is that good? Is that good?
No.
No.
No, never good. Never good. So there's a couple things that I know we went over this, or you went over this with your other professor, is that when you have like a green tinge, brownish looking fluid, and that's thick meconium, we can do an amnio infusion to dilute this, okay? Because this is never good, all right? It does lead to fetal compromise. So it's all according to what phase of the first stage of labor she's in. But if she's in, maybe if she's just getting into the active phase, okay, and she had a bag of water broke, and you saw this green stained fluid, you might think, I think we should probably ask the doctor and do an amnio infusion. And all that means is that we're going to put saline, sterile saline, and we're going to flush out the uterus to dilute the meconium. And we can do that, okay? So an amnio infusion is good for a couple things. One, write this down if you forgot about amnio infusion, but amnio infusion is good to dilute a thick meconium, okay? Amnio infusion is good when she's been in labor for a while and she's had a gross amount of fluid loss, okay? And now you're getting variables. You know those variables we talked about? Because the cord is getting compressed. We can put fluid back in to replace the fluid that she's lost. So that's another good thing about amnio infusions. Okay. Should the amniotic fluid have an odor?
No.
No.
No. What if it has an odor? What happened?
Infection.
Infection. Yes, infection. Good. Okay. So that's a good question too, isn't it? So here's another brain teaser. A woman in active labor experiences spontaneous rupture of membranes. Which nursing actions are appropriate at this time?
B.
Okay. Select all that apply.
A,
A. Uh-huh.
E,
B.
C,
C.
D.
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 D. We don't, and we would not include E, correct?
Yes.
The answer is A, B, C, and D. Good. Okay, good. Good, you got it. Okay, so remember I talked about the psychic and I talked about support? Well, here's the doula. So again, you're helping her cope with labor. That's your job, is coping with labor. And non-pharmacological means of controlling pain in labor. What are those? What are those that you can do for her?
Hydrotherapy.
Yep. Another one?
Sacral pressure.
Sacral. Oh, you saying it?
Oh yeah, the sacral, sacral pressure on the back, right? Yeah, especially if she's OP position. Yeah, what's another one? How about distraction, diversion?
Yes.
Yeah. What about imagery?
Yes.
Yeah, those are all what we call non-pharmacological. That means that the nurses can do them. We can get her on the birthing ball. We can get her up. We can, different position. Remember, I told you that other P to the process of labor and birth is the position. Nurses, we move our patient a lot because those are all considered to be under non-pharmacological. That means there's no medicine involved. Okay. All right. Good. All right. Let's go on. So let's go over the stages of labor because I know you're going to see that for sure. So let's talk about it. Okay, so the first stage is the longest stage. It can last, it only says here from 4 to 6 hours, but it can last a lot longer than that. It has the 3 phases. So the first phase is called the latent, Latent, or you can call it the early. And she's about from 0 to 3 centimeters. This is the time that she's kind of like, hi, nurse. Oh, this is a pretty room. And everything is kind of good. Okay. When she starts to have effective contractions and she starts to dilate, now she gets to be around 4 centimeters, 5 centimeters. She goes into the active phase. So the active phase is from 4 centimeters to 7 centimeters. This is where really a lot of the hard work is done, okay? So during the active phase, if she wants to have an epidural, that's the time to do the epidural, okay? Because then she won't feel her labor pains because during this time, the contractions will get stronger and stronger. Okay. Then she keeps, and this is the time that the doula is very much helping her, or the labor nurse is helping her, or the husband is there. But sometimes the husbands, they get hit around, and a lot of times one time my patient said to her husband, "You did this to me." And then, they got through that active phase. It's a hard time. Okay, now she gets through that and she gets to be 8 centimeters. Now she's in transition phase. So it's from 8 to 10 centimeters. Transition. Okay. Now she's almost done. All right. Now, as we enter in the stage that now there's no more cervix, she feels the pressure, she's in the second stage. And this is where she's going to push. And she pushes. Now, they last from 30 minutes to 2 hours. Okay, remember I told you the OP position, occipital posterior, she may push for longer than 2 hours. This is where we try to cut it off at 2 hours because why? Why do you think we try to make it just 2 hours? Well, we try to make it just 2 hours because the patient can get very tired. Okay, so we try to have effective pushing. That's your second stage. Now the baby's out. Okay, she delivered her baby. She enters into the third stage. And this is where the placenta will be expelled. All right. And this goes from anywhere from 5 to 30 minutes. Basically, we want to make sure the placenta comes out intact. If it comes out and there's some pieces missing on the maternal side, which is the Duncan side, it's called the Duncan, there could be pieces of placenta still up in the uterus. That's called retained placenta fragments. Never good, okay? Because she'll hemorrhage from that. So you want to make sure that when this placenta comes out, it's intact. All right. What's the neonatal side of the placenta called? Anybody?
Shine.
The shiny Schultz. Yeah. Okay. What's the mommy side called?
Dirty
Yeah, come on, you got it.
Dunking.
You got it, Barbara. Good for you. Good. Yep. See how I learned it that way myself over 50 years ago. It never leaves me. It'll never leave you. Okay. And then you have the fourth stage of labor, which is now your recovery, which is a special time called postpartum. And that can last 1 to 2 hours after birth. And then, of course, she goes home, and that 6 to 8 weeks is called the postpartum time. Okay. All righty. So let's talk about a little bit of pain management in labor. What is this called? It's an epidural, right? Okay. In here, I put in here the optimal time is during the active phase of the first stage of labor. We just talked about that. Okay. The main thing is that when this needle goes in your patient's back, she doesn't move. Because if she moves, she can cause herself to have a terrible headache by leakage of cerebral spinal fluid leaking out. And that would cause her to have a terrible, terrible headache. Okay. So how do I correct a terrible headache related to the epidural?
Have her sitting up straight.
Yeah, I'm going to have her position good. But say unfortunately, she moved and they nicked in here, and now she has this terrible headache. What can they do to relieve that? What's that called?
That patch and to sit in a fetal position on her
Yes,
side.
that's called a blood patch. Write that down, blood patch. Okay, and what they'll do is they'll go in. Okay, what we do is it takes two people. So you have a nurse who's taking the blood out of the patient's arm, and it has to be a sterile procedure. Okay, you give the syringe as a 10 ml syringe. And what they do is they'll go in the same place where they did the epidural, and they'll take her blood and they'll inject it into that epidural space, and they're going to close off the leakage right in here. They'll close it off by creating a blood clot, okay? And instantaneously, your patient is much better. Let me tell you, those headaches are related to a problem with the epidural. They're very intense headaches. Okay. So let's go on to another pain relieving modality, and that's called the pudendal block. So the pudendal blocks, so you see the mom's pelvis, and on each side, there's pudendal nerves. Okay. And what we do for vaginal delivery, apparently she doesn't have an epidural, okay? Because an epidural would still give her numbness down her perineum. But she's going with a local, then she's maybe needs a episiotomy. They're going to do a pudendal block. Okay. So a good question would be like, what stage of labor can a pudendal block be given safely? And that would be in the second stage when she's pushing and almost ready to deliver this baby now, is they'll go in and they'll relieve some discomfort in the perineum by doing a pudendal block. Okay. All right. So again, this is what we already went over with you, non-pharmacological. I know everybody's going to have a question on like this, okay? It's just there, non-pharmacological. So we've talked about relaxation. Skin stimulation would be like your effleurage, sacral pressure, We talked about that for OP position. Thermal stimulation, maybe some heat. Diversion and distraction. Imagery, I love imagery. And we always tell the patient to bring their music. And I tell you, these TVs in the birthing room now, the labor and delivery rooms are great because they're nice big screens. Okay. It does help distract the pain. Okay. And then of course you have your control breathing. Now, it doesn't matter which method they go through, as long as hopefully they'll go through some type of childbirth method. But the Lamaze is the most recent. It's it's the most popular. Again, it goes through control breathing. Okay, so let's talk about VBACs. These are vaginal birth after cesareans. So, can you induce? Remember what induction is, right? What's an induction?
Produce contraction. To produce contraction.
You
start the contraction.
Yes, you put your patient into labor, correct? Induction. So you're going to give her Pitocin and you're going to put her into labor because her body's not going into labor. Okay, that's called induction. Now, these type of patients, VBACs, can never have an induction of labor. So that's always a good test question. These type of patients can never have an induction because you can never give them Pitocin before delivery. Because what you have to worry about is that uterine scar, and you don't want it to rupture. All right. So you don't want that uterus to open up and just dehisce. So, because anytime that you cut into an organ, or even your skin, when it heals, even though you sew it up nicely, when it heals, it never has the strength that it had prior to it. So when you cut into, for a cesarean, when you cut into the skin and then you cut into the uterus, all right? And we actually have to cut to get the baby out. Then after the baby's born, we go ahead and sew that uterus back up. So that uterus is closed up. It can hold another pregnancy, but it can never have Pitocin contractions because Pitocin contractions are more intense than a normal release from the pituitary of oxytocin. Okay, they're intense. Pitocin is one of those drugs that are very, very, is a high alert drug. One is very, very, very strong. And that's why we give it in milliunits, very small amounts and very slowly. Okay. And then all this, if she has a dehisce or uterine rupture, it can lead to a hemorrhage. All right. So again, VBACs, you cannot induce. So that's a good test question, is that can you give Pitocin to a VBAC? Okay. So how about a brain teaser? So the nurse is caring for a woman who's delivering her first baby. So which of the following indicates the woman's in the third stage of labor?
D, dog.
Good. I like that. Okay. The nurse is observing a patient for hemorrhage following a delivery. Which assessment finding indicates a maternal hemorrhage is occurring? Select all that apply.
A, B,
D,
C,
C,
D.
D.
and E.
Not E.
Yeah, D. Gotcha.
What?
Sorry.
What would be the fundus if she was having a hemorrhage? What's the condition of that fundus if she was bleeding?
it is soft. It's not firm.
That's right. It'd be soft. It would not be firm. Okay, good. You got it. All righty. How about another question? The nurse assessing a client post-delivery knows the uterus to be hot. Okay, it's high and over to the side. Remember, after delivery, it should be at the level of the umbilicus, right? And midline. So this way, now you come into this room and you see that the uterus is high and displaced to her side. Which is the nurse's priority action?
D.
C. Assess for bladder distension. Yeah,
C.
good. C. Everybody says C?
Yes.
Yeah. C. Okay. All right. Good. Which nursing intervention should the nurse include for a client immediately after delivery to reduce bleeding and bruising of the perineum? Oh, we know that one.
D.
Yeah. Okay. That's a given. That was a good one. All right. We already talked about amnio infusion. Again, it's just putting fluids back into the uterus. We talked about that and diluting the meconium. Okay. So here's your definition of induction. I know you're going to see a question on induction of labor. So what is an induction of labor? It's the initiation of labor before it starts naturally. Remember, oxytocin is released by the pituitary. When a woman goes into normal spontaneous labor, she's secreting oxytocin, which makes her uterus contract. When she does not happen, and she goes like 41, 42 weeks, that means we got to help her. So that's why we have to now give her the drug, which is called Pitocin, Pitocin, is the synthetic form of oxytocin. Okay. And I know you went over the Bishop scoring. We do the Bishop scoring as we are getting this lady ready for an induction. Now, write this down. When you do an induction of labor, we want to be successful, correct? And being successful, we want to have a vaginal delivery, correct? Yeah. Okay. So if this lady's coming in and she's 41 weeks, all right, and I check her and her cervix is thick, guys, it's not effaced. Her dilation maybe 1 centimeter. Oh, the baby's head is like way high. It's like a -3 station. Doesn't sound good, does it? And her cervix is actually posterior. It should be interior when a woman goes into labor. So that's another problem. That's called the Bishop score. I'm going to take all that I saw and I'm going to give a score to all this. Now, remember that a score of 6, and this is a minimum score of 6, is recommended for a favorable induction. So if I have a patient who has a low Bishop score, and what I just described to you is like a very low Bishop score, okay? I think it's like 4. And so if I have that kind of Bishop score, I'm not going to be successful with my labor induction. All right. So in order to have a better go about, and we don't end up with a C-section, because a C-section rate in the United States is way too high, then we're going to go ahead and do a 2-day induction. So she might get that Cervidil, which is like a gel that we put on the cervix to get it ready for the induction the next day. So write that down. The Cervidil is another form of prostaglandin. Remember, prostaglandins is what you need to dilate, to have contractions. So you got the Bishop score. Okay, so just remember, a minimum score of 6 is recommended by the American Congress of Obstetricians and Gynecologists. We want to make sure that this induction of labor is going to be successful, but we don't end up with a C-section. Okay, now, if the woman is in labor, so say she went into spontaneous labor on her own, okay, and she had an epidural, okay? So an epidural can slow down her labor, right? Yeah, it can relax them so wonderfully. It relaxes the uterus, and the uterus no longer is going to contract. We have to maybe give her Pitocin. Again, it would not be a VBAC because you never get Pitocin to a VBAC, but her regular patient, you might have to augment her with Pitocin. So you're augmenting her labor. So you're going to help her to get her contractions back. So medications, especially epidurals, they're wonderful, love them, but also can decrease her labor. Anybody have any question on any of these concepts? Nope. Yes? Nope. Christina, you okay? All right, let me move on. So here is a great slide on contraindications to labor induction. You never, ever, ever will induce a previa. If the umbilical cord is hanging low, you're not going to do that too because you kill a baby that way. If a baby is in transverse lie or in a breech, you're not going to induce a labor. If the baby is like a -5 station, you're not going to induce. Remember, we never deliver through herpes. And again, if she has a plantoid pelvis, you're not going to be very successful in your labor induction. So again, it'd be contraindicated. And then if she has a previous cesarean, you're not going to give perpetocin, which you give when you do a labor induction. So that would be a contraindication. That would be a really good question to ask. Okay. So these are complications that can happen during labor and birth. So you've been through, you talked about these. And so let's see which ones I haven't talked too much about. How about some forceps and vacuum extractor? Okay, we'll talk about that. What's a precipitous birth? It's a labor and birth that all occur within 3 hours. It's a fast birth, and you have hyperstimulation of the uterus when you have a precipitous birth. And so you have to be very careful. Now, a lot of ladies say, "Oh, that's great. Get that done within 3 hours." But it also, she can hemorrhage after having a precipitous birth because the uterus has been contracting so fast that so hyper that after she delivers, the uterus says, "Okay, I'm done. I'm not going to contract anymore," and you end up with a hemorrhage. Not good. Okay, let's move on. All right, so I think we talked about these a little bit, but let me go over these episiotomy with you. Let's see here. Okay, so you got your first degree, and they fall under your laceration. Remember, the peritoneum is the skin is very soft. And so you be very careful with the peritoneal tissue. So the first degree, you're only cutting, a surgical cut, the superficial vaginal mucosa. Okay. Now each time it gets a little worse, if you can see that. So the second degree, you're going to go a little bit more into the vaginal mucosa and the peritoneal skin, and you're going to go into the deeper tissues of the perineum. So you got a second degree. Because remember, I'm cutting, okay? The third degree involves the vaginal mucosa, the peritoneal skin, the deeper tissues of the perineum, but now getting into the anal sphincter area, okay? Not good. And then the fourth degree extends through the anal sphincter into the rectal mucosa. It's like a C-section from below. Now, that can be very painful, all right? And so I've had a patient that had a fourth degree. She had a microsomic baby, which is a large baby. And so we had to extend it, okay? Unfortunately, with your midline episiotomy, it can extend very easily. Okay, you might think, okay, I'm only going to start out with a second degree. That's all I have to cut, But as the baby's head comes down and out, it puts a lot of pressure on that soft skin, and it can just tear it, and it can go thicker. It can go deeper. Okay. All righty. Now forceps. Okay, forceps are used when mommy's pushing in the second stage of labor and she gets tired. So they're going to use these forceps. So let me give you a picture of the forceps. That's what they kind of look like. They're stainless steel. They don't give. And they put it on the baby's head to help guide the baby out. Okay? Because maybe mommy is tired and she just can't do anymore. So we're going to put these on to help pull that baby out. And we do that with her pushing. So she's in the second stage of labor. Maybe she's been pushing for 2 hours. Okay.
That's a long time.
Yeah. Are you tired for this patient, right? And we're going to put this on the baby's head. And when she pushes, we'll pull. All right. And, when we get into newborn, you'll see the different abnormalities that these can cause. Because, again, these are stainless steel. You can see how they're all the different types of forceps, and they are used. Okay.
I have a question, Professor.
Sure. Go ahead.
The forceps, you said they use it while the mommy is pushing.
Yes.
But it's not, the baby is not helping. I think the baby has some phases, right? Rotation. So we don't do it during rotation. The doctor do not do it during the rotation of the baby.
The baby has maybe rotated into a good position, like it's in an OA position, and what we're right there. Okay, it's a low forceps. It's not high forceps. It's a low forceps. And so we put it on there because maybe mom, we're under the bone, the pubic bone. That is a curve. And a lot of times getting that baby through that curve gets really tight. And so mom just can't push anymore, especially if it was a big baby, good sized baby, she just gets tired. So what they do is they put these forceps on and during a contraction now, always during a contraction, as mom is pushing, okay, then they have the forceps and they are help guide this baby out. It's usually to get them around that bone, that curvature. And once that's released, the baby's head comes out a little bit easier. Does that make more sense? But can they hurt the baby?
Thank you.
Oh, it can. It can hurt the baby. Give them facial paralysis. A lot of times they come out very bruised. But this is something else that I like better. It's called a vacuum extractor. So it's the same thing, but let me show you what it looks like. This is called a vacuum extractor. So you see it has a circular format here, and you put this on the baby's head. It's on the side of his head. You never put on the fontanelles, which is the soft area of the baby's head. So you put this on the side, and this is a little pressure gauge. And the nurses we actually set the pressure. So a lot of times I know my patient just needed a little help, So I'm there with it, and doctor says, Irene, how much pressure do you have on this? And I said, oh, about 4, which is pretty low. He says, well, the next contraction, put it up to 10. And I said, oh, okay, you want a 10? Oh, my. And so I say to my patient, I look at her and I say, the next contraction, you push. And you push like you never pushed before in your life. And I set it to 4. We push, and baby comes out. It's just getting around that pubic bone again that I talked about that we do. Nurses, we're our patient's advocate. I don't want to go up to 10 if I don't have to. So, but anyway, let's go on. So that's a vacuum extractor. So you can see that the damage that gets done to the baby the most is that you'll see a little circular indentation, on the baby's head. Not too bad. Not bad at all. It's better than these forceps that are stainless steel that can cause paralysis of the face. So yeah, and this baby can recover a lot sooner, a lot faster with a vacuum extractor. All right, so little brain teaser. What would the nurse expect to assess in an infant who was delivered with the assistance of a vacuum extractor? I know you know this one.
D.
D is in dog, right? Yeah. Which will the nurse expect to observe in an infant delivered? I just did this, didn't I? Oh, no. Okay. With a vacuum extractor. Oh, yeah, I just did this. Circle. Yeah. Okay. Number 3. Okay. Let's go on. All right. So let's talk about.
Sorry, Professor. Sorry. Can you go back to the brain teaser, the other one? Okay, it's like it's similar to the second.
Yeah. Yeah,
But I thought it was facial paralysis, no?
that no, it would be facial paralysis if it said here what forceps, right?
Oh,
But it
but
says yeah, this one says vacuum, and
okay.
so
So
this one
vacuum would
says
be hematoma, right?
it'd be vacuum. It's a circular edema of the scalp, and this one would be circular. It's the same question. I gotta get rid of that one. Hold on, just a minute.
Sorry.
On here, there we go. Okay,
Okay,
all
right?
right, yeah. All right, how about we talk about nursing care after the fourth stage of labor? Okay, all right. And then we have to talk a little bit about preeclampsia, but let's go on. Let's see what we have the preeclampsia. All right, so nursing care after the fourth stage. So what's the fourth stage of labor?
Recovery.
Recovery. Right. Okay, good. All right. So you're going to do your vital signs. Now, what you have to remember, which is a good test question, is that the pulse of a patient can be normal down to it can be bradycardic after delivery. If the patient has a high pulse afterwards, it can indicate that she's having problems, such as maybe an infection, or it could be that she's been bleeding. She's bleeding and she's going into shock, tachycardia. So, what you want to realize is that after delivery, it's normal to have a normal pulse down to bradycardia. That's what I want you to remember. If she has a high pulse, it could indicate an infection or a hemorrhage. Okay. Also, I want you to remember is that you want to check the legs for a thrombus. And that would be a positive Holman's test. So, if your patient on postpartum says to you, I have pain in my leg, you're going to go right down to her room and you're going to check her leg. And sometimes it's warm to the touch, it's red, and she's got pain. And when you just put your hands to it, she's going to say, no, I have pain. That's a positive Holman's test. That means that she could have a DVT. Okay. Remember, blood clotting is increased. So, a lot of times back in labor and delivery, the way we hold her legs up for a long time can cause pressure down in her legs. And so you always want to make sure that you check out, and if she's positive for a Holman's sign, she's got a DVT. Now, DVTs are very, very dangerous because they can travel very quickly up the saphenous vein, up into the pulmonary artery, and cause a pulmonary emboli. So you don't want to take this lightly on a postpartum patient. So just note that you need to check that and what the Holman's sign is all about. That's a good test question. Okay, so why do we do a cesarean? Again, if this little guy won't come out vaginally because maybe mom has an abnormal labor. It's called labor dystocia, which is abnormal labor pattern. Okay, she's going to end up with a C-section. If she has conditions such as gestational hypertension, even diabetes, she may have a macrosomic baby, just wouldn't fit down the pelvis. And you don't want to end up getting a patient in trouble by, she dilates all the way down, the head comes out, and then the shoulders are stuck. Okay, that can happen. The shoulders can get stuck, and then you start thinking, okay, 4th degree episiotomy, and then you have to maybe break the baby's clavicle to get this baby out. So wouldn't it be easier to do a cesarean? Right? Okay. If she has active herpes lesions, guys, cannot deliver a baby through that. It has to be cesarean. If she has a classical incision on her uterus, and that means that's a longitudinal incision line, she doesn't cut, you cannot do a vaginal delivery. If the baby has recurrent late decelerations, you're going to end up with a C-section. So it's called fetal compromise because that baby may be in trouble, be acidotic from hypoxia. And then you have those conditions such as placenta previa or an abruptia we talked about earlier. You end up with a cesarean. Those are all very risky. If you have maybe a twin pregnancy can cause a woman to have dysfunctional labor. The uterus can be over distended and it contributes to poor contraction quality. So you end up with C-section. Now we have done vaginal deliveries on twins to women who have had a proven pelvis. So this is not her first baby. She could be a grand multiparous having twins. So you try to get the baby out. So one is delivered as cephalic, okay, that's head first. And the other one can be breech. And a lot of times we try to change the baby around. We do a version. But a lot of times we'll do a cesarean. Okay. But you know,
I was blessed to have two sets of twins vaginally.
Did you have one done vaginally, a twin delivery?
Both sets, and both sets were over 8 pounds.
Oh, you're a good one. So you had two sets of twins? God bless you.
Yes, and fraternal twins. And the first set, I do remember it was
Yeah.
so shocking because they automatically take you to the OR.
Yeah.
And I kept saying, no, I'm gonna push. I just want to
Yeah.
push. But
Yeah.
first set at 39 and 4, and the second set at 37 and 4.
You are just superwoman.
I try to be.
No, I say that. That's wonderful.
God
It really
bless
is. Hey guys, that's not easy.
No,
So that's why I say that. That's not easy.
Amazing.
That is super, super
God
duper.
bless you, Christina.
Yeah.
Happy
Yes, God
Mother's
bless you.
Day.
But you know, we do.
Thank
We try to work with the mommies, you know. But you know, I hate to tell you, you know who's outside your operating room is those lawyers. And I won't get onto that bandwagon, but a lot of times they're always waiting for something to happen. Okay, let's go on here. But God bless you. You did good. What's your nursing care following a cesarean birth? Well, okay, here's that again, except let's see. I'm gonna get rid of this term here. Hold on just a minute. I think I did this yesterday too. All right. So following a cesarean, you would do your nursing care would be the same as a normal vaginal delivery, but you're going to add the following. Okay. So you do monitoring of the abdominal dressing because don't forget, she's going to have a scar on her tummy. And so we put a big pressure dressing on it. And then we're also going to do a fundal assessment. Now, we may not do it as deep as a vaginal one, but we're going to check the fundus because I cannot have this lady to hemorrhage, okay? And then the lochia, she's going to have lochia rubra, and maybe a little less than a vaginal because I tell you, I used to first assist on cesarean deliveries, and I know that we suction a lot of that blood out. Okay, we try to get it as clean as we can. So that's why the lochia may be a little bit less from inside the uterus than a vaginal delivery. She is going to have a urinary catheter. Okay, we got to keep that bladder flat so that we keep the uterus quiet and at the level of the umbilicus, and it's going to involute just like vaginal delivery. Respiratory care, cough and deep breathe as needed. Prevention of a thrombophlebitis. Remember, clotting factors are increased, so she can throw a clot really easily. And then, of course, we always worry about pain management. Okay. Okay, so Natalie, I just read some of your chat. Some of your slides are going over, not on my end. Oh, sorry. Shouldn't be. Can you see the Natalie? Can you see the slides now? Hello?
I can see them, but I noticed you were going back and forth, so as I'm following them, but I know it's
Okay.
just that weren't up here because I have 114 slides. I wasn't
Yeah.
sure.
Yeah. Yeah. Okay. All right. How about a test question? All right. So, which will the nurse anticipate assessing in a client following a cesarean? So, select all that apply.
All.
Oh, yeah, you're gonna do all
Yes.
that. Yeah. Just remember, she's got to be watched just as she has surgery, so you have to be very careful with her. And her lochia is still going to be the same because it comes from the inside of the uterus. INO for the urinary output, vital signs, blood pressure has to be assessed. The fundus has to be firm. So you do your assessment. And of course, you're going to look at that incisional dressing and make sure that if you have like a little spot on the incision, the dressing, okay, I always put a little circle around it. And then when I go back to check again, if it goes outside that little circle, she has more active bleeding underneath it. That's a little hint. That's a little tip. Okay. Here we go. So another brain teaser. So which information will the nurse include when discussing Kegel exercises with a postpartum client?
Okay.
A, Kegel exercises help strengthen the muscles involved in urination. Absolutely. Those are one exercises she can do after delivery that will actually help her with urination, and it helps her later in life. Okay. All right. The APGAR score, I'm sure that you all love the APGAR score, but why do we do the APGAR score?
To assess the baby's well-being.
Yeah. So know we know what level of resuscitation, right, that this baby needs. So we look at, so I thought this was another way of looking at this mnemonic here. So I put APGAR here. You put A for appearance. Okay, so appearance would be your skin color. So if this baby is quite blue, don't you think? Okay, so I would give it a 0, correct? There's no color. It's all blue. Now this baby here, his trunk is pink, but the extremities, and usually it's just the hands and feet, is blue. That would be a 1. Now this little guy over here, he's doing real good. He's got good circulation, right? So he's got a 2. So each one, so now we go to P, which is your pulse, okay, heart rate, right? So if I have nothing, it's going to be a 0. If I have something, if I have 100, right, or less, it's going to be a 1, right? Okay. Remember, normal is from what? 110 to 160. And then greater than 100, I'm going to give him a 2. Okay. So I give him good credit for his heart rate. Okay. Then you go to grimace. Now, a lot of times, HESI, and I know test questions, they like to use the term grimace for reflex. So if you got some kind of grimacing, here, look at this guy. He's kind of letting you know I'm not too happy about what we're doing. He's a 2. Compared to this guy here, he's a little floppy, all right? He may have had a little trouble coming down the birth canal, and so he's a little tired here, so he has no response. Okay. And then A would be your muscle tone or your activity. So here, I got no movement. Again, I'm flaccid when I'm born. And then here I got a little flexion, okay? But here I'm active. I'm doing good. This baby is in good shape. Okay. Now R means for respirations. If you're not breathing, okay, is that pretty bad if you're not breathing?
Yeah.
It is. If no breathing, you get a 0, folks. If you have a weak or slow cry, you're trying to breathe, right? So you get a 1. And then here, if I got a vigorous cry, which I love, that to me is like music to my ears in the delivery room, then I give them a 2. Now, what you do is you total up the points, and you do it at 1 minute and 5 minutes of birth. Okay. And then if you see the score down here, so, if I have a score of 7 to 10, I'm in good shape. Because don't forget, each one has a score. And then if I have a score of 4 to 6, I'm a little bit depressed. I may need a little help. I may need some, good stimulation. I used to rub those babies' backs, drying while I'm drying them off, and I get them good and pink. And then they get a little aggravated, and so they cry. They give me a good cry, and then I got my score to come up. And then if my baby comes out and we're real flaccid, we're in this kind of first column here. Okay. You can see this baby's not doing good. Okay. I don't have any breathing. I have no movement. I have no grimace. I'm really flaccid, floppy. I have no pulse. That's a bad sign. Then you have to do big resuscitation, complete resuscitation, because I'm severely depressed. So I hope maybe that this little picture here helped you a little bit trying to understand about APGAR. Because Dr. Virginia APGAR is a really fine physician, and she came up with this to help healthcare providers and nurses in the delivery room to assess these babies very quickly and to respond very quickly to their needs. All righty. Let's see. This is a slide. Which one you want to get is body temperature is so important to the newborn. Okay. So a big problem at birth would be regulating thermoregulation. Okay, to make sure that the baby stays warm. Because when a baby gets cold, you can what we call cold stress this baby out, and that can cause respiratory distress in the baby. So you don't want to have a cold baby, which would be hypothermia, because hypothermia, the baby's going to use a lot of his blood sugar up to try to warm himself. Because remember, babies don't shiver, they don't sweat or anything in the very beginning. So he's going to use everything he's got inside, which is his blood sugar, to make him warmer. Okay. And then he uses all the blood sugar up. And so because he's so cold, he goes into respiratory distress. So that's why making sure that babies are warm. So how can I make sure my baby is warm in the delivery room?
Skin to skin.
Keeping it warm.
Well, you got the radium warmer, right? Okay.
Yeah.
So that radium warmer you have in the delivery room. And so, or the labor room, because we have LDRs, labor delivery recovery. And so you have the radium warmer on. You always want to make sure that you have him warm. Now, also another big thing is having their ID bracelets on before leaving the labor room or the operating room. So remember, that's a really good question though. So you want to make sure that you always have the ID bracelets on before leaving the labor room, LDR, or the operating room. Okay, let's go down here. So if I was to ask you which security, hold on, let me just make this a little slower. Which security measure will the nurse take when bringing the client's newborn from the nursery to the mother's room?
D.
D as in dog?
Yes.
Yes. All the other ones is not going to make sure. I mean, everybody can say, is this your ID number? Yeah. This is the only one that would be a definite, right? Is to match up. Okay. Let's see here. I would suggest that you know the normal vital signs for an infant. So again, the heart rate is just like it was pre-birth, 110 to 160, and the respiration 30 to 60 breaths per minute. Okay, those are two that I definitely would know, and the temperature, because those are good test questions to ask. And I'll tell you who likes those kind of questions is HESI when you come down to HESI. All right, so how about another question? Which of the following intervention best promotes bonding following delivery?
B.
Yeah, B. Good. All right, let's talk about breastfeeding. I think breastfeeding is on this test too. So, is colostrum good?
Yes.
Yeah, why?
The antibodies.
Has antibodies.
Antibodies. Good, 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 good. What are the two hormones that are needed with breastfeeding?
Prolactin and
Lacting and
oxytocin.
Prolactin and oxytocin. What does prolactin do?
uh,
Produce.
produce milk.
Causes production of milk. Okay, good. What does oxytocin do?
Make the milk come out.
Yeah. Remember oxytocin? You've been seeing oxytocin a lot in the labor room, right? With the contractions and oxytocin, and afterwards, because it contracts. Same thing in the breast. It contracts the milk ejection and makes sure it comes down. Yeah, exactly. Those are two major things. Good, good. So if the nurse is discussing the different phases of milk production with the patient, so which phase of milk production will the nurse refer to when talking about the phase of milk production that contains protective antibodies?
D.
Yes, good. You got it. You got it. All right. Now, when you're assisting a mom to breastfeed,
Excuse me.
yes.
Did she say B or D?
Oh, let me go back.
Colostrum.
You said
B, right?
colostrum. Yeah.
B.
Colostrum.
Yeah.
Okay.
B. Yeah, good. B is in boy, right?
Yes.
Yes. Yeah. Good, good, good. Yeah, that's always a good test question, by the way. Yeah, always a good one. All right, so let's go here. And this, I know, let me make sure. I'm looking at my notes myself real quick here. Postpartum breastfeeding support. Okay, it's on my list. All right, so breastfeeding techniques. Positions of the mom's hands. That's important, right? How about latching on? How should a baby latch on so that mom doesn't get sore nipples?
Use the finger.
Hmm?
The mom. Oh no.
No. How many?
Okay, the nipple should go all the way inside.
Right. So this brown area called the areola, right? Should be, he should latch on to that whole area. The reason why I'm going over this because it's a good question. Because if they don't latch on like this, all right, and they only latch on to the nipple, that causes mom redness of the nipple, and that nipple can crack and it can open up, and that's very painful. Then if you have an opening into the body, she can get an infection, and that infection is called mastitis. So we don't want mom to have mastitis. So we're going to prevent that by making sure that the infant latches on with the entire areola in his mouth. Okay. And this is really important concept because we want to make sure mom doesn't get sick. It makes sense. Now, on the other hand, when you're taking off the breast, okay, I think Barbara, this is what you were alluding to, is that you're going to break that suction, right? Yes. So you get your finger, you tell mom, a clean finger, by the way, and puts it in the side of his mouth to break the seal. Because when a baby latches on, it does grab on. Usually the mothers go, woo! I can feel that because it's a good suction. But when you're going to take the baby off the breast, you just can't pull the baby off the breast. Okay. Now here's an example of what we call engorgement. So engorgement is never good, right? It hurts. The breasts get really full. So you can see here. So here, engorge. See how, look at the ducts. See, look at all these lobbles. They're just really, 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 really full compared to here. That means it's just not getting through, is engorged. The milk glands are just too full. They're not getting through. She's not having the proper letdown and release. So she gets engorged. Now this can happen even if she's breastfeeding, but that means she's not feeding enough. Okay. Also, if she is not breastfeeding, she wants to bottle feed. This is what can happen because the body knows that it should produce the milk, right? You have prolactin and oxytocin going on, and it should but she's not using this. So she has maybe put some ice packs on her breasts, no stimulation to the breast, and then after a few weeks, it'll die down. But the breasts get very full and very heavy. Okay, be very uncomfortable. Now, here's an example of mastitis. So, do you see why I would want to do the right latching on and the right breaking the seal when mom's breastfeeding? Because you do not want mastitis. Because the breast gets very enlarged, it's very red, and this hurts. It hurts a lot, and it can also travel up underneath her armpits and include the tailspence under the arms. So this is what we want to avoid at all costs. Okay. Now, a lot of moms ask, how do I know my baby's getting enough of fluids? Okay. And we tell them, because they say that they see the colostrum and they see how thin it is. And they go, very thin. My baby getting it. Yes, the baby's getting fine. She gets a lot of antibodies. Colostrum is good. And I know the baby's getting enough fluid by the infant having 6 to 8 wet diapers per day. Okay. So I know then he's getting enough. So that's a good test question. All righty. And of course, the infant passes several stools during the day. It's another way of evaluating. And another way, too, that the baby, when he feeds, should empty those breasts. So her breast should feel soft after feeding. So that's another way. And then moms, you got the baby, the breast, can hear him swallowing. And then you're going to at least feed the baby for 15 minutes per breast, 8 to 10 times per day. Remember, you need at least 10 times to prevent ovulation from happening. We talked about that. All righty. All right, so I've got another question here. So which of the following indicates successful breastfeeding is occurring? All right, you know that one.
A.
A, okay. Would you like to have these kind of questions on the test, right? All right, which nursing action best provides a postpartum client pain relief from breast engorgement?
C.
C, yeah. And also, what works really good for that is cabbage leaves on the breast. Okay. Another good question could be about nutrition during breastfeeding. So remember, mommies need to have 500 calories when they're breastfeeding. Okay. They need to drink lots of water. The more water fluids they get in, the more milk they can produce. And then some foods eaten by mom can cause a change in the taste of the milk or cause the infant to develop gas. If you eat a lot of chocolate, you can cause the baby to have what? More diarrhea. If you so everything, let me remember something. Anything that mom takes in may be secreted in the breast milk. Okay, let's talk about weaning, because I think there's a question probably on weaning. So if you to wean your baby off the breast, what should you do first? How would you go about it?
Formula.
Well, yeah, you're gonna probably go to formula, right?
Yeah.
So your technique of weaning the baby off is to eliminate one feeding at a time. Okay, one feeding. And they say to omit the daytime feedings first. And they eliminate the favorite feeding last. Usually, the nighttime feeding is also referred to as comfort nursing. Okay, so you want to eliminate that one last, because that's a special time between mom and baby. It's usually in the evening, or especially if the infant is overly tired or not feeling well, he needs that extra comforting. That's usually that's the last one you're going to wean off. And it's not easy to wean off the baby, is it? If you ever breastfed, it's kind of hard on both mom and baby. It's psychological. All righty. So The lactation nurse has provided breastfeeding education for a new mother. So when discussing weaning, which statement by the mother indicates the need for further teaching?
D as in dog.
So slow weaning, let's look at them. Slow, so this is, remember, needs for further teaching. So 3 of them are correct and 1 is not, right? So slow weaning allows me time to adjust psychologically to the new change. Okay.
D.
Okay. Yeah. Slow weaning helps prevent my breast from becoming engorged. Yeah, that's good too, right? C is I can choose to wean my child when I'm most comfortable.
No.
No. Yeah, that's the need for further teaching. And then look at D. Abrupt weaning is easier because we can move quicker to a cup or bottle. Oh, so which one would you say they need for further teaching?
It would be C.
D.
You say C. What about D?
I
It
said
would be D, but
If I said that, oh, well, abrupt weaning is easier because we can just move quickly to a cup of bottle.
I
Is
was
that
Yeah.
good for the baby?
no.
no.
No, not at
No.
all. No. And mom can
And-
choose to wean her child when she's most comfortable. Because remember, it's never, it's never a good, really great time to do it, right? But you always want to do the daytime first and then leave the nighttime to last because we talked about comfort feeding. But abrupt weaning is easier because we can move quicker to a cup of bottle. Nah, I think D. Don't you think D needs further teaching?
yeah, that's what I said. D.
Yeah, I do. I agree with you. Yeah. See, I'm agreeing with you. Oh, this is well, we already did that. Okay, let's get rid of that slide. Huh. We talked about that already. All right. Oh my goodness. Okay, so let's see. We did this one too. I think I have some repeats here. Hold on here. Did we talk about amiotomy? All right. So what's an amiotomy, folks? Let me see here.
There are membranes.
Yeah, what we do with those membranes? We are rupturing those membranes. So it's artificial rupture membranes. That's what you have to why do we do it? We have to, there is done to stimulate or enhance contractions. As a nurse, now knowing this, as a nurse, when the doctor or the provider ruptures the membranes, what do I have to be concerned about?
The amount,
Ex-
the color, the odor,
Right. Yeah, color, odor, the amount, correct.
and baby
Also,
outbreak.
also
Right.
what else I have to worry about?
Infection.
Well, not so much infection yet. I know now we are committed, right, to delivering this patient within 24 hours, correct?
Heart rate.
Yeah, fetal heart rate. That is exactly right. Yeah, I've got to make sure the fetal heart rate stays between the normal limits, 110 to 160, because you have to worry about prolapse cord. Remember we talked about the head being too high and the cord could prolapse? Yeah. And then, of course, we're committed to delivery. If we don't get her delivered within 24 hours, we can have a complication of infection. Another one, too, but thank God it doesn't happen too often. Sometimes the provider's a little rough, breaking the bag of water, and you can get abruptio placentae. But thank goodness that doesn't happen too often. All right. Talked about that already. Let's go on here. We talked about non-pharmaceutical methods to stimulate contractions. Walking is the best one. And we also have another one called nipple stimulation of labor. When you stimulate the nipples, then you activate the release of the natural oxytocin from the pituitary gland. This we don't use very often because we can't quantify it. I don't know how many mLs of oxytocin is being released by the pituitary gland through the nipples. So this is hard. You have to be very careful when you're stimulating contractions using nipple stimulation. All right, let's see what we got. We talked about episiotomy, so I think we're good on that. What about diet? What kind of diet should a woman have if she has a third-degree laceration following a vaginal delivery?
Increase protein.
Yeah, you got protein, fruits, vegetables, right? High fiber diet, right? Would help to make sure that, because what a third degree is all the way down to what? The anal sphincter, right?
Prevent
So,
constipation.
yeah. Would your patient would be really scared to have that bowel movement if she had a third degree laceration. She's bruised, guys. She's it's all red, and here, she's hardly walking and she knows she has to have a bowel movement, but she is scared. So you want to always encourage a high fiber diet and lots of water to get things going. All
But
right.
aren't they giving stool softeners as well?
Yeah, what stool softener do you see a lot in the hospital?
Like Dococet,
Um,
Senna,
we use Colace a lot. Yeah,
Colate.
Colace. Yeah. Okay. All right. So nursing care and recovery room. So if we had a C-section, all right. And I think we already went over this, but the main thing I want you to know is the vital signs to identify hemorrhage or shock. Okay. Got to be on alert. The first sign if somebody's going into shock is tachycardia. The pulse will go up. So say we know it's normal to have a normal pulse or even bradycardia after delivery because she loses a lot of blood. Okay. All right. And now you have her in the recovery room and you all of a sudden, your patient's not doing too good and you notice her pulse is like up to 120. And then she has some rapid breathing, maybe some tachypnea. Are you concerned? What are you going to do? You're going to check that fundus, right, for firmness. And where is that, right? I'm also going to check her dressing for drainage because I got to find out where she's bleeding from. And then lochia, you want to look at her lochia rubra because it might have a few little clots, but it shouldn't have a lot of clots. And then her urinary output, making sure the kidneys are still working. So you have a lot to think about after a C-section in the recovery room. All righty. I think you all know the reason behind inserting a urinary Foley catheter before cesarean. Why do you do that?
To avoid a deviation of the pelvis, no, of the uterus.
Yeah, you want to make sure that when you go into the uterus, that when you're starting to cut, when you're cutting through somebody, the bladder lays right underneath the uterus. So the bladder can get nicked so easily when we're going in. So we're actually deflating the bladder by putting a Foley catheter in so that when we go in, that it's clear. We don't have any problems going in. All right, let's see what we got here. We talked about the psychic. All right, we already talked about prolonged labor in there. Okay. I kind of touched upon the precipitous birth, and I said it was less than 3 hours. It's labor and birth all within 3 hours. What you have to remember of that is that it causes the uterus is now contracting very, very quickly. It's called hyperstimulation of the uterus. Another term that you might have heard about is called tachysystole. These are contractions that are like every minute, guys. They're every minute, up and down. Frequency is terrific. So what happens is that because of this rapid contraction pattern, it can cause uterine rupture. It can cause cervical lacerations or even worse, a hematoma in the vulva, which is very, very painful. So, these kind of deliveries are a problem, and fetal oxygenation can be compromised because don't forget, this baby's coming down rapidly. And sometimes the baby can have an injury and from intracranial hemorrhages. Okay, because he's coming down the pelvis, the passageway, so fast that his top of his head, you can cause a little bit of hemorrhaging up in his head, and worse, you can cause some nerve damage. So again, these are things you have to think about. And this patient too is more prone to a hemorrhage after delivery. All right. So what type of complication could occur after precipitous delivery?
2.
Yeah, hemorrhage. Good. Okay. All right. We talked about rupture membranes, and we talked about Lysine paper. So we've done that. Let me skip over here. Let's see what else we got here. I know it's getting kind of long. Let's check. Let's go over some medications real quick. Let's go over some tocolytic therapy. Also, medications that we use for what? Preeclampsia. We haven't hit on preeclampsia. So, okay. So let's talk about first tocolytic therapy. So a tocolytic therapy our goal is to stop uterine contractions. Now, you're probably saying, what the heck? We've been talking about induction and augmentation of labor and the patient going into labor. Well, now we may have a patient who is preterm. And so now we want to stop a contraction. The medication that works beautifully, because how it works on the body, is magnesium sulfate. Now, we do use magnesium sulfate for preeclampsia. It's because it's a central nervous system depressant. So it shuts down the central nervous system. So therefore, it would shut down the contractions if we needed to. And with preeclampsia, hypertension, right? Magnesium sulfate prevents seizures. Remember that? So what's the antidote that's used when you have magnesium sulfate toxicity in a patient?
Calcium glutamate.
Yeah.
Yes. Okay, good. So again, calcium gluconate is given to reverse the magnesium sulfate toxicity. Good. All right. All right. All right. Now, another tocolytic would be brethine or terbutaline. And one thing about that is that you have to be worried about the patient's heart rate, okay, brethine, because it's a bronchodilator and it makes her heart rate go up. So that's your priority assessment of a patient who's taking terbutaline, would be her heart rate. All right, let me see what I got here. All right. Let's see. Oh my goodness. Prolonged pregnancy. I guess we haven't done post-term yet. Okay, well, let's keep going. Let me see my check-off list here. Let me see. Preterm labor, episiotomy, C-section, postpartum hemorrhage, postpartum care after vaginal delivery, postpartum care, newborn, postpartum care, breastfeeding. Okay. Let's talk a little bit about prolonged pregnancy. So remember, prolonged pregnancy is pregnancy that lasts longer than 41 weeks. Why do we have to worry about prolonged pregnancies? Anybody?
The placenta may not work as well.
Yeah, the placenta, it gets old. It calcifies or it ages. All right. So the fetus, his little skin may start to peel. They get bigger inside. So it means that, maybe they're going to be more prone to a cesarean delivery rather than vaginal delivery. Baby may have meconium stained fluid. That may happen. And so then you may have some low blood glucose levels in the fetus. So when a patient gets to around 41 weeks, I start to get a little nervous. So, okay. So let's see here. Some emergencies during childbirth. We talked about prolapse cord. We know that. And uterine rupture we talked about. Okay, we're good. I'm just seeing what I got here for you. Some postpartum complications. Yeah, that's on my list here. So let's go over that. So we talked about shock already. And we talked about tachycardia being the first thing you see, right? And then hemorrhage. How many mLs of blood should, let me put it this way. If you have a vaginal delivery, and how many mLs would be considered a hemorrhage in a vaginal delivery?
I think like 300, right?
Okay, vaginal delivery would be 500.
500.
Okay, yeah. And how many mLs would be a hemorrhage in this following cesarean delivery?
Is it 1,000?
1,000. Good, good. Okay, another postpartum complication could be, remember we said the Holman sign, the DVT, thromboembolic disorders because of increased clotting. Okay. How about infections? We talked about chorioamnitis, right? Subinvolution of the uterus. What's that? What do you think subinvolution of the uterus is?
It's getting bigger, maybe, instead of.
Okay, so let's break this down. Let's break it down. So involution of the uterus means the uterus is contracting back to its pre-pregnancy state, right? If I have subinvolution, that means it's not as good as involution, right? Is below. So this subinvolution is a slow return of the uterus to the pre-pregnancy state. And an indication or cause of subinvolution would be retained placenta fragments. So say the patient was at home and she should now be, well, maybe she's still in the hospital, put it this way. And so after delivery, she should be at the level of the umbilicus, correct? Okay. But she's not. She's still above the umbilicus and she's a couple days post-delivery. She's subinvoluting. She's going down very slowly. So then you would have to start to think why. And it could be from retained placenta fragments. Okay. And another complication of postpartum is mood disorders. All righty. We talked about shock. So here. We talked about the first sign of shock is most often tachycardia. We talked about that already.
Yeah.
All right. I'm just trying to see here what we need to do. I think we did a lot of this already. We can talk about early postpartum hemorrhage. The cause of this would be uterine atony, that's a uterus without tone, or lacerations or tears of the reproductive tract, or the hematoma. Remember we talked about the hematoma in the vulva from a precipitous delivery. Those are all causes of early postpartum hemorrhage. That means the hemorrhage occurs very quickly after birth, okay? Very quickly. So on uterine atony, uterus without tone, you would do what? Fundal massage, right? Okay. With a laceration or tear, you would have a trickle of blood and you would have to, her fundus could be firm but she still has a trickle of blood coming out and it's constant. So that means that she has a laceration maybe higher up in the uterus. And the hematoma is usually in the vulva area, and that's a collection of blood in the vulva. These are early postpartum hemorrhages. They all can cause the patient to hemorrhage and to then go into shock. Okay. Let's see. This is on uterine atony, which I told you would be a soft, boggy uterus. All right, so let's see. Let's go do some questions here. Okay, so which medication would the nurse anticipate prescribed to control postpartum uterine atony?
The Triboline.
Yeah, well, postpartum uterine atony, that would be a soft, boggy uterus, and that would be Mepigen. So look up Mepigen if you're not familiar with Mepigen. let's see here. The nurse assesses a postpartum client and notices, oh, uterine atony. So which action should the nurse perform first?
4.
Yeah, massage that fundus. Okay. All right. I talked about lacerations like a trickle of blood. And whenever you find that you have something abnormal going on, you always want to keep your patient NPO. Okay, NPO, because you never know when she's going to go back for surgery. Let's see here. We're talking about hematoma. Hematomas are very, very painful. Very, very painful. Okay, I'm just trying to see here where we're up to. Oh, what is the nursing action that's appropriate in the care of a postpartum patient to prevent fundal displacement?
Number
So, which one?
3.
2,
Who said 2?
me.
And you're right, Barbara. It's 2. Because when the bladder, which lays right underneath the uterus, gets full, it pushes that uterus up and over to the side. And so when you see a fundal displacement, that means you got to empty that bladder. So I would ask the patient to void. Now, if she can't void, I may have to do a straight cath on her, but I'll get it. All right, so this is just a slide on subinvolution that I've already gone over with you. And let's see here. All right. In nursing care of a woman with just a slow return would be, well, we want to report any abnormal pattern. So we're going to, look for any kind of foul smelling vaginal discharge or pain. Pain is always a good indicator something's not right. And then, of course, persistent red lochia. That's indicating of placenta, retained placenta fragments. And knowing that in order to get those fragments out, she's probably going to need a curettage, dilatation, curettage. She's going to need to be cleaned out. So she's probably going to go for a surgical intervention. Okay. Oh, here's a nice question on this. Classical symptoms of DVT include muscle pain, positive Homan sign, and swelling on the affected limb. Is that true or false?
True.
True. You got it. Okay. All right. So this is just nursing care to prevent a thrombo. So you watch for signs of PE. We talked about pulmonary embolism. Always, guys, in any patient that's going to throw a PE on you, they're going to have difficulty breathing. They're going to have a cough and some chest pains. Okay. All right. What we're going to do, we're going to get them out of bed after surgery and get them going with the range of motion exercises and walking. Get them out of bed. All right. Your patient is 5 weeks post-vaginal delivery. During the doctor's visit, the patient states that she noticed foul-smelling drainage. She's got a pelvic discomfort, and she has been running a slight fever. The nurse relays these findings to which of the following? What would be the
Number
cause?
3.
Okay, now go back to the question.
2.
Yeah, this is
Choices.
foul-smelling drainage, pelvic discomfort,
Mm.
and been running a slight fever. Yeah, that's
Endometriosis.
a inflammation of the endometrium, which is called endometriitis. All right. Okay. Now I want to touch base on preeclampsia. So what do we have to worry about preeclampsia? It's hypertension, right? When does preeclampsia occur?
1.
Oh no, this is not. Don't look at this anymore. Here, hold on. Let me go.
Oh.
Okay. I'm reading my notes, so I want to make sure I go over preeclampsia with you. So, preeclampsia. When did you show his dirty face? I would say after 20 weeks, right? After 20 weeks. What medication are you going to use to prevent a seizure with a preeclamptic patient?
Magnesium sulfate.
Good, you got it. Okay. what medication would lower blood pressure in a preeclamptic patient if you had to use an antihypertensive medication? Write this down. Labetalol, or hydralazine. So labetalol is spelled Labetalol, or hydralazine is Hydralazine. Okay, so what kind of a hospital, what kind of nursing action would you do? What kind of a hospital room would you put this patient in?
By herself?
Be a quiet,
Yes,
right?
yeah.
Yeah,
In a-
low stimulation room. Yeah. Would you pad her side rails?
Yeah.
No, but keep the
Yeah.
rails up.
Because she can
Yeah.
have a seizure.
That's right. You want to pad her side rails. Yeah, because she could have a seizure. Okay. Even though you're giving her magnesium sulfate not to have a seizure, of course, that's your goal, but you want to prepare for anything that could happen. So you definitely would pad her side rails. You definitely have a continuous pulse ox on her and continuous blood pressure monitor on her, and always maintain her airway and limited visitors, correct? Because you need to have her quiet, right?
Yes.
Correct? Okay.
Yes.
All right. Tell me the difference between placenta previa and placenta abruption.
Placenta previa is bright red.
Okay.
And abruption is dark red.
Correct. You are correct. What about the pain?
It's painless and previa.
Okay. Good. What about abruption?
It's not painful. I don't think she experienced.
Abruption. Would she have pain with abruption?
No.
Yes.
Yeah.
It would be real severe.
You are it's very severe pain. It's her uterus is like it's hard.
Like a board.
It's like
It's
a
like a
board. Yeah, board-like. And so that's how it's described a lot. So it would be painful. Remember something. Anything like it's going to abrupt, even the word abrupting, doesn't that sound painful to you? Yeah, it is. It's painful. Okay. Let me stop sharing here. Hold on just a minute. Okay. There we go. All right. So yes, it would be painful. What about her abdomen on a previa when you assess it?
Firm.
It would be firm, yes.
A previa would be soft, right? Because there's no pain, right? What about abruption? What's her abdomen going to be like? We just talked about it.
The opposite, yes.
hard.
Hard, yeah, board-like. Good. That's the difference. So on those kind of questions, you want to really read, what is the question asking me as to how I'm going to answer it. Okay, good. All right. I'm just making sure that I go over everything with you. Okay. We talked about that. We talked about preterm. We talked about prolonged pregnancy. We talked about precipitous labor. We talked about induction and augmentation of birth. We talked about that. Indications. Okay. I'm just making sure. False versus true labor. The stages of labor. Know them, guys. Know them like the back of your hand. Okay. Let me see here. Let me just stop